morning, everyone. Welcome to another episode of Spilling Tea. I am your host, Tiffany Daniels. We're going to go over a few quick things, just the usual real fast, and we're going to go ahead and hop into it because I kind of started this vid a little bit later than usual. All right, folks. So, first things first, in regards to this FDA executive summary, bleh. As always, you are going to be able to find the link to that in the description, as well as the first video that I have done on the JRC since finding out that the ban was not enforced on electroshocks, and also including below that the change.org petition in order to shut down the Judge Rotenberg Center. If you haven't already signed that, folks, please go ahead and do so. We need all the help we can get at this point. It's drug out already far, far, far too long. That being said, folks, some of the things we discuss when we are talking about the Judge Rotenberg Center do include vivid descriptions and depictions of people with disabilities being tortured. So when you are watching these videos, it is heavily advised, even if you have older children, to please go ahead and use your headphones. Now, if I by chance happen to horribly mangle any scientific term or jargon, or if I happen to stumble over my words because it's early morning and let's face it, I'm barely awake, then, folks, I do go ahead and apologize in advance. Okay, without further ado, we are starting Section 7 today, which is going to be the summary. Alright, so let's jump into it here. FDA is considering a ban on ESDs, that's electric skin shock devices, for aversive conditioning that are intended to administer a noxious electrical stimulus to patients exhibiting self-injurious behavior, acronym SIB. We go over this every morning, folks. And the FDA is concerned, SIB and aggressive behavior because, in light of other available treatment options and new information, FDA is concerned that they present a substantial and unreasonable risk of illness or injury. The FDA is convening this advisory panel meeting to seek, scientific and clinical expert opinion on the risks and benefits of these devices and to obtain recommendations that will assist the agency in deciding whether or not to ban the devices. Section 516 of the Food and Drug Cosmetic Act authorizes the FDA to ban, by regulation, any device intended for human use that presents substantial deception or unreasonable and substantial risk of illness or injury. When making this decision, the FDA must weigh the benefits with the risks of these devices. All available data and information must be considered, including benefits and risks associated with other available treatments. 7.1 Other available treatments for SIB and aggressive behavior. This is summing up some of the stuff we've already went through. Since the decision to ban a device must be made in consideration of the available alternative treatments, FDA provided information on a number of treatment options for patients exhibiting SIB, including aggressive behaviors. These options include pharmacological, behavioral, and other non-electrical therapies. Currently, there are no published consensus guidelines or practice parameters for the treatment of SIB and aggressive behavior for individuals with limited intellectual ability or developmental disabilities. A review of the published literature suggests that behavioral treatment should be the first-line treatment, notably when environmental factors contributing to the occurrence of SIB and aggressive behavior can be identified. However, there does not appear to be any consensus in the literature regarding the type of behavior intervention that should be employed first. Pharmacological interventions are typically used in conjunction with behavioral treatment program or when allergies. are typically used in conjunction with behavioral treatment program or when patients do not respond to behavioral therapy. The majority of treatment studies are limited to either a single case report or a small case series. Despite the numerous methodical limitations of the published literature, overall, both pharmacological and behavioral interventions appear to be relatively successful in reducing, but not completely eliminating, SIB and aggressive behavior in persons with intellectual or developmental limitations. Remember, I told you that a while ago. Nothing's going to take away the urges entirely. It comes with the diagnosis, unfortunately, but they can be significantly reduced when treated correctly. Moving on. Reporting of adverse events, with exception of pharmacological studies, is sparse, and few behavioral studies report adverse events. There are 2 pharmacological treatments for autism spectrum disorders approved by the FDA, risperidone and aproprazole, which they never put me on, curiously enough. It was always Adderall, God knows why. The adverse event profiles in antipsychotic agents such as risperidone and aproprazole appear to be similar to that reported for many psychiatric disorders, including sedation, weight gain, development of involuntary movements, e.g. tardive dyskinesia, dystonia, and akathisia, elevated prolactin levels, cardiac conduction changes. And neuroleptic malignant syndrome, McDougall et al., 2002, Matson et al., 2008, Robb, 2010. Some of the more common adverse events associated with other pharmacological treatments, SSRIs, tricyclic antidepressants, opiate antagonists, mood stabilizers, and alpha agonists, are headache, hyperactive behavior, gastrointestinal effects. Okay, let's face it. If you're autistic, not every one of us has gastrointestinal issues, but there's a good number of us who do. And the medicine's not going to create something that wasn't already there. Just putting that out there. Anxiety, sexual dysfunction, weight gain, dry mouth, sedation, changes in appetite, and skin rashes. Mood stabilizers, including lithium and anticonvulsant agents, often require monitoring of cardiac function and kidney function and routine blood tests to assess for evidence of toxicity that can be associated with several serious adverse events, including coma and death. The panel will be asked to discuss whether they believe there are effective treatment alternatives, both FDA approved or used in the practice of medicine, to ESDs for aversive conditioning that are intended to administer a noxious electrical stimulus to a patient exhibiting SIB and aggressive behavior. And if so, they will be asked to discuss the benefits of these treatments compared to these risks. One thing they seem to refrain from saying is the potential for the abuse of these devices, like what we have seen at the Judge Rotenberg Center, are extremely high. Not only are these devices not recommended because it's literally torturing someone for something that is out of their control, punishing them for things beyond their control. Essentially, also, the fact that somebody could use this device that is designed to cause harm and use it above even the prescribed amount that the JRC says is normal is just too high. So, just that being said, let's go ahead and move on here. 7.2, benefits and risks of ESDs for aversive conditioning. FDA provided a discussion of the benefits and risks associated with ESDs for aversive conditioning for several indications, including SIB and aggressive behaviors associated with developmental disabilities. The information consists of public scientific literature information provided to the FDA, independent reports, information from other federal agencies, public hearings, clinical interviews conducted by the FDA, and media reports. The published scientific literature represents the highest quality information available, but given the absence of systematically conducted, well-controlled prospective investigations, any conclusions should be cautiously considered. In contrast to the systematic literature review, information from other sources may be more susceptible to bias given the lack of peer review, the motivations of the authors, and the circumstances in which the information was presented. Therefore, this information should also be cautiously considered. Guys, this is, remember when they commented that a lot of this information is from 80, 60, 30 years ago when treatment ethics looked a hell of a lot different than from what they look like today. So, that's why it should be cautiously considered. Also, back then, there are psychological disorders that come from abuse and harm that weren't even considered back in the day. So, whereas a person can now consider PTSD a high psychological risk factor when we are talking about these kind of treatments, back then, that wouldn't necessarily have been so. And also, any of the studies that the JRC is going to provide is going to be clearly skewed and biased to their side. So, that's kind of what it's stating there. 7.2.1 benefits. The literature review and other sources of information suggest that short-term benefit is supported, while significant concerns exist about the long-term effectiveness. The FDA literature review results are similar to that of two noted researchers in the field, Skinner and Levis, who also concluded that punishment methods, Skinner, and ESD for aversive conditioning, Levis, demonstrate short-term benefit but lack demonstrated long-term durability. However, there are concerns regarding the quality of available information as noted in the preceding section. The panel will be asked to discuss whether the available evidence demonstrates ESDs for aversive conditioning intending to deliver a noxious stimulus to a patient exhibiting SIB and aggressive behavior is an effective treatment, and if so, for what specific populations of patients has effectiveness been demonstrated? Which clearly, as we've gone throughout this, we've only shown that it has not. Okay. I'm going to close this out here in a minute, but I just want to go over a couple more. 7.2.2 risks. Patients may experience adverse physical and psychological harms from the use of ESDs for aversive conditioning. The following potential risks were identified by the FDA from literature review and other sources of information. Other negative emotional reactions or behaviors, burns, and other tissue damage, anxiety, acute stress, PTSD, fear and aversion avoidance, pain and discomfort, depression, and possible suicidality, substitution of other negative behaviors, including aggression, device malnutrition, psychosis, and neurological symptoms and injury. It should be noted that the published literature suffers from evolving standards of AE reporting, i.e., more recent publications are more likely to present adverse events, with 26 of 45 articles being published before 1980. We just talked about that a moment ago. Of the 45 articles reporting clinical data, 17 contain no report of whether the subjects experienced AEs or not, and only 3 reported any systematic method to monitor AEs. The panel will be asked whether the FDA has provided a complete list of risks and whether there are any additional risks that you think should be included. 7.2.3 Treatment Resistance. When treating persons with developmental or intellectual disabilities, the behavioral intervention should be the least restrictive option available that still results in behavioral reduction. Fox, 2005. The balance of risk and potential benefit of using aversive conditioning ESDs would be most favorable in a population that is refractory to less invasive treatment modalities. FDA is not aware of any criteria identifying refractory patients or any rigorous systematically collected data that would inform or question of whether a population exists that is refractory to adequate trials of other available treatment modalities. provided by the appropriately qualified clinicians, or who are unable to tolerate such treatment modalities due to side effects. Anecdotal reports may be found of persons who are apparently refractory to all behavior controls except ESDs for aversive conditioning. Israel et al. 2008. Of course, that's what he would say. Along with reports of persons who were successfully treated with less restrictive methods after ESDs for aversive conditioning were previously used. Bird and Luzelli, 2000. Gotta love those folks who counteract that bastard. Moving on. I just like to see it. I'm seeing it. Okay. So we're actually almost all finished with this. So I'm going to go ahead and finish it out. The panel will be asked to consider whether the specific population of patients that is refractory to adequate treatment attempts using other available treatment options, and for whom these devices would be only the effective treatment and which benefits outweigh the risks. Labeling and restrictions on device use. Before banning a device, FDA must make a specific determination that the substantial deception or unreasonable and substantial risk cannot be eliminated by a change in the labeling for the device. Additionally, there may be other mitigations, such as device restrictions, that could correct or eliminate any unreasonable and substantial risks posed by the evidence. Examples of potential risk mitigation through labeling or other restrictions include, but are not limited to, device technological restrictions, electrical stimulation, output parameters, limitation of number and location of electrode permitted on individual, etc. Labeling restrictions, e.g., use in treating only certain populations, treatment refractory patient populations, patients in certain age groups, etc., or use in treating only when significant, life-threatening, self-injurious, and or assaultive aggressive behaviors are being exhibited. The panel will also ask to comment on whether labeling or any other mitigation, such as restricting use of device, could correct or eliminate a substantial and unreasonable risk of illness or injury for any population, and if so, they will be asked to identify the labeling change or restriction and discuss how it will address the risk. Assessment of unreasonable and substantial risk. Section 516 of the FD&C Act, 21 U.S.C. and 360F set forth the standard for banning devices. Under that provision, in order to ban a device, the FDA must make a finding that a device presents an unreasonable and substantial risk of illness or injury based on all available data and information. The panel will be asked to discuss whether the device presents a substantial and unreasonable risk of illness or injury. In their response, they will be asked to consider the benefits in relation to risks, in light of other available treatments, whether there is a specific population of patients for which the devices would be only effective treatment, and their reasoning. 7.5 Additional questions. Additionally, as part of its banning analysis, FDA must consider whether devices should be removed from those currently receiving treatment. If the panel recommends, the FDA determines that the device is present an unreasonable... Kitten! Seriously? Sorry, folks. I don't have an edit button. Shush! Alright. Let me read that over again. If the panel recommends it, FDA determines that the device is present and a reasonable significant risk of illness or injury, they will be asked to discuss whether devices should be removed from patients currently receiving the treatment. Cat, stop! 7.6 Ethical considerations related to clinical studies. It is determined that clinical data on ESDs for aversive conditioning is needed. The question of whether a clinical trial can be conducted is raised. However, there are ethical concerns with the use of ESDs for aversive conditioning, intending to deliver a noxious stimulus to a patient exhibiting self-injurious behavior, SIB, and aggressive behavior FDA is concerned that due to known risks of ESDs and possible alternatives, the use of these devices in clinical studies, particularly in children, may not even be approvable under FDA regulations. Isn't that interesting, folks? Isn't that just interesting? The panel will be asked to discuss the circumstances, if any, under which a clinical trial could be conducted to evaluate ESDs for aversive conditioning for the treatment of SIB and aggressive behavior, such that the risks of the subjects outweighed by the anticipated benefits to the subjects and the importance of the knowledge to be gained. I mean, folks, that pretty much covers it. What we're taking a look at here is all the sources, and we've gotten into the appendixes. So apparently, we've finally finished it. And that pretty much sums everything up that we've gone over throughout the entire course of this gigantic document. So I really can't really say anything that they haven't already used to wrap everything up. So without further ado, folks, we don't get very many views on this channel. The few that we do tend to get removed from time to time. So folks, please don't forget to hit that like button. Hit subscribe. And folks, please don't forget to hit the comments. I do appreciate your time this morning. And as always, folks, we here at Spilling Tea hope you have a good one. Bye-bye.